Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. Today, I am honored to present three distinguished guests who will help you delve into the recent publication, The Role of Pretherapy Quantitative Imaging Dosimetry and Radioiodine Therapy in Advanced Thyroid Cancer. First, we have Jan Taprogge, a clinical scientist with an impressive background in nuclear physics. Currently, he contributes significantly to the radioisotope physics group at the Royal Marsden Hospital at the UK as a medical physics expert. Jan earned his PhD in theoretical nuclear physics from the Universidad Autónoma de Madrid in 2015 and furthered his expertise in and Masters of Science in Clinical Science from the King's College in London in 2018. He is at the forefront of setting up, running, and analyzing dosimetry data from prominent clinical trials such as Selimetry, MIRROR, and INSPIRE. Moreover, Jan leads the molecular radiotherapy team in the Radiotherapy Trials Quality Assurance Group in the central UK, resource dedicated to designing and implementing Q&A programs in NIHR, CNR, CRN portfolio trials. Our second guest, Professor Jonathan Wadsley, has been a consultant clinical oncologist in Watson Park Hospital in Sheffield since 2004. He brings a wealth of knowledge in thyroid cancer, neuroendocrine tumors, and pancreatic biliary tract cancers. With a specialized interest in molecular radiotherapy, his research is closely aligned to his clinical interest, focusing notably in thyroid cancer and neuroendocrine tumors. Professor Wadsley is an active member of the NCRI Thyroid Cancer Subgroup and serves as clinical director of the Sheffield Clinical Cancer Trials Center, cancer specialty lead for the Yorkshire and Humber Clinical Research Network, and holds a role in the NIHR National Specialty Lead for Radiotherapy and Imaging. Lastly, our discussant for today, Dr. Munir Ghesani, is an associate professor of radiology at the Icahn School of Medicine at the Mount Sinai and the systems chief in nuclear medicine and molecular imaging at Mount Sinai in New York. Dr. Ghesani spearheads a thriving theragnostics program at Mount Sinai, which not only benefits patients in the Mount Sinai health system, but also attracts referrals from across the northeast of the nation. With over 200 publications in peer-reviewed journals and 150 presentations worldwide, he has held leadership positions in several prestigious societies, including being the immediate past president of the Society of Nuclear Medicine and Molecular Imaging. So it's all red carpets today. Great panel to start this discussion. Before we begin, I would like to encourage all the audience to send in their questions through our Q&A function, and we'll try to get as many of them by the end of the hour. So with no further ado, I'm gonna hand off the microphone to Dr. Taprogge to start the presentation.
Yeah, thank you very much for the invitation. And so yeah, I'm going to be presenting today on this imaging and dosimetry results from the Selimetry study. And I've got John Wadsley with me, who is the PI of the study. So hopefully he will be able to answer any more clinical questions. Where I'm going to be more a medical physics expert, so I'm going to be focusing more on the physics behind it. So just a couple of disclosures. So the Selimetry study received funding from Cancer Research UK and AstraZeneca, and the RHTSH was provided by Sanofi Genzyme. So just a quick introduction. So when I'm going to be talking about molecular radiotherapy in all of the slides, I was referring to the use of internally distributed unsealed radioactive substances, which have been used obviously for a long time now to treat benign and malignant diseases. And like looking back, obviously the first example really was the radioiodine for thyroid cancer and benign thyroid disease, which really has been used for over 80 years now. We've got other examples like I went through on MMBG for neuroblastomas, and then newer things like PSMA with lutetium for prostate cancer. But there's obviously lots of new ones coming in, so it's really it's a long list that I couldn't just put here all on the slide. And when we're looking at molecular radiotherapy in the clinic at the moment, it's obviously for most of it we're using a one-size-fits-all approach. There are a couple of examples where we don't do that. For example, for the MIBGs, where you might either scale by patient weight or even go by whole body doses. But for the majority of treatments, we're giving the same activity, the same frequencies for all our patients. But going back to the basic principles, we would really expect that the response should be related to the amount, no, should be not be related to the amount of radioactivity given, but to the radiation doses received by the target. So really more like an external beam radiotherapy approach, which we were trying to give a certain radiation dose to the targets while limiting doses to the organs at risk. The slides are not just going to focus on dosimetry. I'm also really interested in quantitative imaging, and especially from the like SPECT side of views. And I think it's really like a tool that that can really help to provide additional information. And it's something I'm going to be showing some of the Selimetry results are really focusing more on the quantitative imaging and how this can be used for patient stratification. The problem with molecular radiotherapy is obviously it's a relatively rare therapy, which in the past, most of the studies have only been single center studies, especially anything that involved dosimetry and quantitative imaging. So, and even big centers like the Royal Marsden were obviously only like treating a couple of patients a week, maybe a little bit more, but by far don't have enough patients to like collect sufficient data to like make any like major findings. So it's really about multi-centered trials. And the problem there for the quantitative imaging and the dosimetry is that this isn't standardized at the moment. So it's really something that requires quite a lot of work in the background from the physics side, like setting up QA programs and everything. And yeah, so I'm going to be talking a bit about that, but mostly focusing on the results from the Selimetry trial. So Selimetry trial is set in the advanced thyroid cancer setting. So it's obviously the most common endocrine malignancy, both in the US and UK. And it's so if we're looking at thyroid cancer, it's obviously usually treated by initial thyroidectomy and then followed by potential treatment. And I know there's obviously lots of controversy going on between ATA and other guidelines about if to treat or not to treat with radioiodine. And there have been lots of studies recently looking into that. But yeah, we're really looking more at those patients that have been treated, and then obviously for the majority of them it works really well, but there is a significant number of patients that will become eventually resistant to the radioiodine. So that's when we talk about the radioiodine refractory thyroid cancer. And over the years, there have obviously been lots of different approaches been taken trying to resensitize those patients to for further radioiodine treatment, things like lithium carbonate or something like that. But one other approach is obviously to actually target the molecular pathway, and one of those approaches is using a MEK inhibitor to try to resensitize the patients. And one of those examples is Selumetinib, and Selumetinib was first used in this setting at Sloan Kettering by Ho et al. Who looked at 20 patients, and they gave them 4 weeks of Selumetinib and had an I-124 PET scan before they're giving the Selumetinib, and an I-124 PET scan afterwards, trying to look at the increase in the uptakes. And they also looked at using those PET scans to predict the radiation doses that the tumors would receive after therapy. And so patients went on to therapy when they were projected to receive at least 20 gray. Out of those 20 patients, an increased uptake was seen in 12 patients, and 8 actually went on to have radioiodine therapy because they reached those 20 gray. So Selimetry really was built on the back of that and was a phase 2 multi-center UK trial. And it was really about trying to reproduce the finding of that pilot study in a larger multi-center study. And it was also to look then at the broader clinical impact. So our primary endpoint was progression-free survival at 12 months. But a big thing about the Selimetry trial was also, and that's what I'm mostly going to be focusing about today, was to look at the symmetry for personalization of the treatment. And so the overall recruitment target was 60 patients. So the next couple of slides, I'm just going to run through kind of like the main clinical results, and all of that has been published by Dr. Wadsley in Thyroid last year. And so just a summary of the main clinical results of the Selimetry study. So unfortunately, we had to stop recruitment after 30 patients because we had a much slower recruitment rate than was anticipated, and the conversion rate of patients who had a higher radioiodine uptake after Selumetinib was lower than we had anticipated from the pilot study. So we had to stop at that point because just recruitment just wasn't feasible. Out of those 30 patients, 2 patients weren't included in the analysis because one was found to be ineligible after randomization and the other one withdrew from treatment. And so out of those 28 patients, 11 patients showed sufficiently increased uptake to go for further radioiodine treatment, and 9 actually received further radioiodine treatment. So the other 2, there was just clinical factors that prevented us from proceeding with the radioiodine treatment. So, and from a clinical side, really the main results was what was really interesting was that like a dose reduction was necessary in most of the patients because all of them had some kind of adverse effects or toxicities. And but the progression-free survival at 12 months was actually very good with 4.8%. But because we had such a limited cohort, the confidence intervals of that are obviously quite wide. And even though it was just about higher than what we would see in a normal cohort in that thing, it's we really need to like look. This study really needs to be repeated with a bigger cohort to look properly at the progression-free survival. So yeah, so as I said, all of the participants reported at least one adverse event. About half of that was grade 1 or 2, about half of that was grade 3, and in one patient we had a grade 4 event. So just to summarize really the clinical bits, so like I think we've really seen really promising clinical efficacy with this progression-free survival of 64.8%. But like I said, study was underpowered, and I think it's really something that should be brought forward and investigated again in a bigger trial. And but then compared to the Howard et al. Study, the tolerability of Selumetinib was really found to be worse, and with lots of reductions or delays in treatment in most of the patients. So like I said, quantitative imaging and dosimetry was really an essential part of the trial. So I'm going to be focusing on that for the rest of the study. Try to keep it as less physicsy as possible. But there's obviously a couple of physics concepts that I will have to introduce you to. But otherwise, really have a read of John Wadsley's publication in Thyroid to like get more of the kind of clinical things, and he will be able to answer any clinical questions at the end of this. So, like I said, dosimetry was really an essential part of the trial. So there was a quite detailed scanning schedule that all the patients had to follow. And so before we gave the Selumetinib, each patient got an I123 SPECT CT scan and a whole body scan. It was just like to look at the baseline uptake. So we could look at how the uptake increased after 4 weeks of Selumetinib. They then had, after the 4 weeks of Selumetinib, they had a second I123 injection, and then followed by up to 5 scans. So we have the 24-hour scan, again, SPECT CT and whole body, which could be used to like assess the increased lesion uptake, and based on that, we could make a decision if patients were suitable for further radioiodine treatment. But additionally, we had up to 4 additional SPECT CT scans for dosimetry calculations, so that we can use the I123 diagnostic scans to predict the radiation doses received by the tumors after therapy, which we would then wanted to compare to the actual delivered absorbed doses. So if patients had an increased lesion uptake, they went on to I131 therapy, and it was a standard UK approach of a fixed activity of 5.5 gigabecquerels, and then again followed by 4 SPECT CT scans, which were then used for the dosimetry calculations. So we had like pre-therapy dosimetry and post-therapy dosimetry to compare to each other and to really look at that bit about personalization of treatment. Like I said, lots of our work was around the quality assurance as well, because quantitative imaging and dosimetry really isn't as standardized as it should be at the moment. If we're looking at like multi-center trials for molecular radiotherapy, it's all about consistency. So we set up a system for with questionnaires and everything to like actually figure out the technical capabilities at each center and the resources. Then 2 of our staff went around to perform site setup measurements so that we had consistent quantification on all systems. And we had to decide on standardized, but also practical protocols that could be implemented at each sites, because there's obviously a range of gamma cameras that were used for the imaging, some older, some newer models. So it was really about that. And I think it was, at least in the UK, the first MRT multi-center trial that involved a full QA program. And it's something that was mentioned in the beginning, that I'm part of what is called the Radiotherapy Trials Quality Assurance Group in the UK. And because it's obviously really common practice in external beam radiotherapy, multi-center clinical trials. So we really built a lot around that. And then for this trial, we performed centralized dosimetry, but if the dosimetry would be performed in each center, additional quality assurance really would have been necessary. So just from a physics point of view, so we obviously had to set up all of the cameras for quantitative imaging, and my colleagues Becky and Francesca went around to set up all of the centers. And there was 3 main measurements we had to do, where we have to do a dead time correction, where because especially on the first day of therapy, after the therapy, the patients are quite radioactive, so that will kind of lead to saturation of the detector. So we need to be able to correct for that, to do accurate quantification. We obviously got a very limited spatial resolution of our SPECT CT systems, which leads, especially for smaller volumes, might lead to apparent loss in activity. So we have to be able to correct for that. And then really the most important factor, obviously most SPECT or whole body scans at the moment aren't quantitative. So we really need a conversion factor to go from the number of counts in an image to the actual activity. Yeah, so that brings me really into the quantitative imaging results for the Selimetry study, and I think it was really one of the main bits we have been working on. So, and the first bit was really to look at how Selumetinib changed the uptake in those patients, and what intra-patient variability there was. So on the graph, it's really shown the relative increase in the iodine uptake post Selumetinib treatment. So comparing baseline uptake to after 4 weeks of Selumetinib. And then we've got those 9 patients that had increased uptake and went onto radioiodine therapy, shown here. And for each patient, we did as many lesions as we could identify. So there's some patients had only a small number of lesions, some had more, and we've classed them into lung, soft tissue, and bone lesions. And the really interesting bit here is really to see the and I think when you look on the y-axis, so it's a relative increase, and it's but it's a logarithmic scale, so we're talking 5 orders of magnitude here. So there's some patients where it works well, it increases the uptake by a factor of 4 or 5, but there's other patients where it works really well, and we have an increase by a factor of 100. But then even within patients, we see a massive range. So if we look, for example, at patient 20 that has quite a lot of lesions, we really see 3 to 4 orders of magnitude differences between different lesions. So there's certain specifics to factors to each lesion of how well they react to the Selumetinib and how well they increase the uptake. So it's really something that needs to be taken into account when then subsequently doing the treatment decision for the radioiodine, is to really look at the individual changes and to kind of use this quantitative imaging data as well. Then we also had a look at if there was any correlation between the relative increase in the uptake with the baseline uptake, because it was something that we were interested in. Does it also work in patients who still have got some uptake, or does it work better in patients who don't have any uptake anymore at all? And well, there seems to be a slight decrease based on the pre-Selumetinib radioiodine uptake. There was not found any statistically significant difference, and it's something that really just shows that even for patients who have a decent uptake still before we went in with the Selumetinib, even for them, we can achieve a factor of 10 or something like that increase in the lesion uptake, and therefore really increase based on that the doses that we would be delivering in those patients. And it's obviously something that has been assessed as well so I think Selumetinib nowadays now has also been checked by the Sloan Kettering group in a setting of non-refractory patients. So it's something that has been looked at afterwards, and it's really interesting to see that Selumetinib might be something that if we do the dosimetry and we see that we really would have to give lots more activity to receive to like treat to a certain dose threshold. Things like those like Selumetinib or any other MEK inhibitors might be something that we could use to actually boost the dose in lesions if possible. So from a quantitative imaging side, it's really, it was really interesting to see that significant inter and interpatient variability that we found, like how the Selumetinib worked and increased the radioiodine uptake in different patients and different lesions in one patient. So it's really something that we should be looking at before we proceed with radioiodine therapy. We looked at patient lesion-specific biomarkers, so TG, we looked at lesion sizes, lesion uptake, like I said, and everything. Unfortunately, because of the small patient set and the small number of lesions in total, we couldn't find any predictive uptake markers. So we really need to like go back and do some further work in a larger patient cohort to identify any like patient stratification factors that would tell us in which patients the Selumetinib works better or worse. So yeah, like I said, it didn't, unfortunately, luckily it didn't correlate with the baseline uptake. So Selumetinib really might be effective as well in non-refractory patients. So patients that still have a bit of or like some degree of radioiodine uptake, and might really be something that might be used as like a to increase the doses that we deliver to those patients. And so we should be really going forward and look at Selumetinib or other related drugs. There's obviously different bits in the pathway that we could be targeting in the molecular pathway to like help those patients with advanced differentiated thyroid cancer. Yeah, so those were really like the quantitative imaging results. Obviously, if we're doing quantitative imaging, we can also do dosimetry. So that's what we and like I said before, we really wanted to look at like the difference between the I1-3 and the I1-1 dosimetry. So I'm just going to give a very quick overview of what we have to do to like get a dose to a lesion, and it's really simple in the way that the only thing we really need is we need a number of radioactive decays that happen in a certain tumor or a certain organ at risk. So we need to image our patient at multiple time points. We need to measure the amount of radioactive substance in the tissue. And then we need to add a very simplified conversion factor, and that can be done in multiple ways to actually convert those number of decays into a radiation dose. But it really isn't that complicated. So for Selimetry, we really wanted to focus on comparing the pre-therapy dosimetry with the post-therapy dosimetry, because if we want to go forward with an interventional trial where we actually want to look at treating to a certain radiation dose, we need to be very confident that whatever we predict pre-therapy correlates with what has been done, what we then measure post-therapy after actually giving the radioiodine therapy. So like I said, we have like a limited, we had like 5 scans after the I1-3 and 4 scans after the I1-1 to get our dosimetry results. And like because the I1-3 has such a much shorter half-life and everything, it was really important to look at, can we actually predict the I1-1 absorbed doses that we're delivering after therapy. So with all of the patients, we're both for I1-3 and I1-1, we start with 4 to 5 CTs and 4 to 5 SPECT images. For the CTs, we obviously have to get lesion volumes, because radiation dose is the amount of energy deposited per volume. So we need to know the volume that we're talking about of the lesion. Then we need our conversion factor that we use to calculate the radiation dose. I'm not going to go into too much details here. But then on the SPECT side, we need to quantify the SPECTs, and then we need to somehow bring the outlines that we've done on our CT, ideally, onto our SPECT. And there's obviously might be misalignment, there might be blurring, especially in like lung lesions or something like that. So it is actually something that we have to be quite careful about, and that I'm going to talk a bit more about that in the next couple of slides as well. And then from the SPECT imaging, so from the number of from the activity in the lesions at different time points, we then get our what we call the cumulated activity, so just the number of radioactive decays that are happening, and then we're getting to our absorbed dose. And something I'm also going to be focusing on is like we always do provide to all our absorbed doses that we calculate, we provide the uncertainties, because it's really something important, as you will be seeing when we go through the slides now. So the first bit really, and it's just a couple of images from some of the patients, is like how like the lesion volumes from the CT outline, just showing like how easy or difficult it can be sometimes. So we've got like one of the patients here, and like you have like a lesion like in the left thyroid bed. And then you've got the fused image with a low dose CT, where you can see where that lesion is, and then what the outline that our radiologist has done to that. And it's really something as well to stress is the like kind of like work together between the physics department and the radiologists here, which was really crucial for the trial. And I think will be also if dosimetry goes further into the clinic, it's really something we have to work together to get these like accurate results. Then if we go into something more like a lung lesion or something like that, where it becomes really more complicated, because especially in those patients, they're often very diffuse lung mets, and so you really have to like work with your fused images of the SPECT images and the CT, trying to identify which parts of it are the ones that are actually taking up the radioiodine. Because like I said, it is how much energy we deposit per unit mass. So it's really important to get that mass as accurate as possible. And it's something that luckily, because we had so many CTs for those patients, so like we had 4 to 5 SPECT CTs for each patient, and we did outlining on all of those CTs, we could really get an idea of what mass uncertainties we're outlining. So like the radiologists outlined the same bit on like the 4 or 5 different CTs that they have. So we could get like an estimate of like, for like some lesions, like we're really talking about like 5% uncertainty or something like that. But if we're going to the like really smaller lesions, we're really getting into like 20-30% uncertainty, and that will directly propagate through to the estimates of the absorbed doses, as we will see later, which is really important to then, if we want to tell that to our clinician how certain we are about the radiation doses that we're delivering. So then the next bit is, and that's something we have worked quite a bit on, is like how we get the lesion volume from the CT onto the SPECT, because it's obviously, especially if we're talking about lung lesions again, so it's like, as you can see, there's one lesion outlined by our radiologist. But if we then look at the SPECT overlaid on that, it's really like, because of the breathing motion, and due to the long acquisition times of the SPECT and everything, it's really hard to kind of like get those two aligned together and get like an accurate measure. So we have done quite a bit of work on like methods where we just draw like large volumes of interest, but like multiple ones of them, to like really measure the background activity and estimate uncertainties in those in those activities, so that we get a good estimate of how certain we are in the doses that we are providing to our clinicians. And then, yeah, so really the bit then goes into the absorbed doses and, as I said, the uncertainties, because it's, from our point of view, it's really essential, and you're going to see it on the graphs later, that when we're looking at comparing the I-123 with the I-131, is that we can communicate how confident we are in those absorbed doses, especially if we want to compare ourselves to external beam therapy or something like that. So we do have lots of little bits, like I said, the outlining, the quantification and everything, where we introduce in quite large uncertainties. So like I said, there's some lesions where we're more confident. So like the one in the left thyroid band, like we estimated like about a 10% uncertainty. But if we then go into those smaller lung lesions, you're ending up with like a 50% or more uncertainty, which isn't a bad thing. It's just important to highlight is if we are, and I think it's something that we have when we talk to our clinicians a lot. It's really more about like, we're more talking about now degrees of like of gray. Like I would never tell our clinicians that that we're delivering 10.2 gray, because that would be a lie. But it's more about, they want to know, are we going to deliver 1 gray? Are we going to deliver 10 gray? Are we going to deliver 100 gray? Because then you can really make then you know, even though if you've got big uncertainties, you're quite certain you're going to be below or above a certain dose threshold when they get established. So this really brings me to the main result that we had for the dosimetry bit, which was to look at like comparing what we predict from the I-123 pre-therapy dosimetry compared with the absorbed doses that we actually measure post-therapy. So we've got on the x-axis the predicted absorbed doses pre-therapy, and then on the y-axis we've got the absorbed doses post-therapy. So in an ideal world, all of those would be lying on that line of identity that I've drawn there. They're obviously not, but because we've got those uncertainties in there, actually most of them hit that line of identity, and there's only a couple of lesions where we're clearly predicting something wrong or something quite far away from the line of identity. But overall, there's a really good agreement between the predicted absorbed doses and the absorbed doses post-therapy, really showing that we can predict what a patient would get, and based on that we could adopt the activity given or something like that to hit a certain dose threshold for those lesions. And again, as you can see, they are quite large uncertainties, especially because we're talking about logarithmic scales here. But like I said before, if you're predicting a gray, it might be a gray, it might be 2 gray, but you're quite certain that it might not be enough. While if you're predicting 1,000 gray, it might in the end only be 800 gray or something like that, but it is really like the order of magnitude that you're predicting correctly, and which can then really leads into like personalization of treatment. So like I said, yeah, so we also looked a bit more into like the differences between the predicted and the measured absorbed doses, and we found that the absolute deviation really increases when we go up to higher doses. But it's really what we think. It's about to identify those patients that are likely not to respond to therapy and that might need other options because the doses would just be too low. And it really brings us into the potential for treatment planning. So just to summarize those results, it's really, so we saw, and that's not something I've said specifically, but you could see the wide range of absorbed doses that we've observed. So like from like basically 0 gray up to like 1,000 gray. But we have seen that the I-123 treatment planning is feasible, and that we've really found a good correlation between those two. And as I said, it's really from our point of view, uncertainties are really important to communicate if we're talking about dosimetry in molecular radiotherapy. I'm just going to do a couple more slides on like some of the work we did after Selimetry. Selimetry really was for us just a start into like multi-center trials for molecular radiotherapy, including dosimetry. And one bit I'm going to just have a couple of slides on is Medirod, which was like multi-center European study where we recruited 100 patients. So now we went away from the advanced thyroid cancer, went into like the differentiated thyroid cancer patient just after thyroidectomy. So it was 4 centers in Germany, France, and the UK. And so it was just ablation patients, so 1.1 or 3.7 gigabecquerels with mode of TSH stimulation up to the clinician. And the main result of that trial was really more to look at the absorbed doses to healthy organs. So like we did quite a lot of imaging and looked at the absorbed doses delivered to different organs at risk, but also any other organs, and really showing the large range of absorbed doses and these absorbed doses per unit administered activity, just showing that there's orders of magnitude differences between patients, especially even for things like salivary glands or like L2, L4, which is like a surrogate for the bone marrow absorbed dose, just showing that like personalization really might be necessary. And another thing we showed there was that we had some patients with 1.1 and some patients with 3.7 gigabecquerels treated. And we looked at like the absorbed doses per unit administered activity for both whole body and salivary glands, and we didn't find any significant difference per unit administered activity, really showing that the absorbed doses scale with the activity. And that really brings me to my like summary and my conclusions. So I think, and I like to show this as a little puzzle where we have been working really over the last 10 years towards like personalization of radioiodine molecular radiotherapy. And it's really about the first bit, and I think it's really something that we're still working on. It's really important is the standardization of quantitative imaging and dosimetry. There's so many different ways of doing dosimetry that we really have to like, if we want to go forward and collect really good evidence for the fact that dosimetry might be useful, that is really like a first bit that is really important. The second bit, then, that was the bit I talked about today, was really like the showing that pre and post therapy dosimetry is feasible in a multi-center setting, and we've done it. We're now doing it for other studies afterwards. And then the the next bit is that absorbed doses do seem to scale linearly with administered activity, really making it possible to like scale the activity up or down depending on if we want to like deliver a certain dose or if we want to like spare a certain organ at risk. And then the group in Germany, in Essen, by Jensen et al., really has done a lot on the dose-response relationship and has shown some really good initial results of that. There will be a dose-response relationship in radioiodine treatment for the lesions. And yeah, so I just wanted to say thank you to John Wadsley on the call as well, who might be able to answer any clinical questions. And obviously all of the study teams at all of the different centers we've worked with, both in the UK and in Europe for all of this. Thank you.
Jan, thank you very much for this very interesting presentation. We're going to go ahead with Dr. Ghesani's discussion. We'll come back to questions if the audience has any, so we can start the discussion. But it's really interesting data that you're showing here, and we'll come back to it in a bit. Dr. Ghesani.
Congratulations on remarkable work. The way you presented and the way the physics part of it is done, it is just, very pioneering work. And we really, really congratulate you on how important it is to show that in order to use the personalization, you need to do a lot of different steps and to be able to deliver these treatments based on individual patients' needs. Camilo, one thing is my Zoom is asking me to restart before I can share. So Salman, if you don't mind, if you can share my screen and I can go over the discussion part of it. Let me also give you a little bit of historical background of how this is taking us back 90 years. It was in 1937 when there was a meeting in Boston. It was sponsored by MIT, and the president of MIT at that time, Compton, is doing this seminar that's titled, "What Can Physics Do for Medicine?" And it was just remarkable what physics has actually done for medicine over the last 90 years. And in the audience was Sol Hertz, who at the end asked the question, can the iodine be made radioactive? And Compton says to him, well, let's discuss it and let's meet up. And they meet up. And simultaneously, many other centers were trying, but they started with treatment for leukemia. But Sol Hertz was specifically interested in thyroid. And the very first attempt he made was in treating the hyperthyroid state. As Dr. Taprogge mentioned that, his key sentence was, it's not about the radioactivity that is administered, but it is the dose received. And that key word was, in fact, pioneered in late 30s, where they started doing some measurement in the uptake, and then we would treat the patients based on the uptake in the neck, not based on just pure administered activity. As we started moving into thyroid cancer treatment, some scenarios still do that, but in many, we have moved away from it, and now we have to turn full circle back and try to adopt that principle for every single patient. So if you can go to the next slide. I don't have any relevant conflict of interest, and this is the article we are discussing. So the next slide. And this is the group. Congratulations again for doing this very valuable multi-center study. Next slide. And so we'll go through these specific steps. So we'll understand the research context, evaluate the study structure and methodologies, assess the data, results, and conclusions, and go to the future direction. So next slide. Let's go to the first step. Paradigm shift, as I mentioned, personalized approach. And as you mentioned, Dr. Taprogge, one-size-fits-all approach is one very predominantly used. In fact, when we treat the Lutathera and PSMA, lutetium PSMA, again, it is something that we have to order as a unit dose. But I'm at a meeting in Orlando at the SNMMI, and a large part of this meeting discussion is focused on how we can move away from it and go into personalized dosimetry. So I'll talk more about it, but the key bullet item is the second one, which is response is not related to the administered activity, but rather absorbed dose by the tumor, which is why the quantitative imaging and post-therapy dosimetry are very, very critical. Next one. And so I'll show you, you may be aware of one of the pioneering data in a study called Dosisphere. And that study had looked at individual doses received by the lesions in the liver for those patients who are receiving intra-arterial Y90 therapies. And this study was so impressive that they had to interrupt the study early because ethically it was not considered appropriate to have the patients in the control arm who are missing out on the benefit of that particular approach. We, in fact, have at Mount Sinai done some work on this, and so role of pre-therapy quantitative imaging and dosimetry in, radioiodine therapy or advanced thyroid cancer. Next slide. And then we have also worked on the specific aspect of Y90, where we would do the MAA pre-therapy treatment planning and then compare that with Y90 PET-CT. So the bottom row is using the MAA, and then the top row is, in fact, after administering that treatment, looking at the correlation based on the ROI concept that was described by Dr. Taprogge. So next slide. So, you saw the linearity between your pre-therapy and post-therapy imaging and looking at that linearity. And we did the same way. We looked at the tumor to normal tissue dosimetry ratios and looking at that value. So if you can go to the next slide. Again, deriving these volumes based on PET-CT, but also looking at the MRI to correlate those ROIs and then looking at the overall treatment dose delivered. Now we were asked question, well, yes, so we have a correlation between the pre-therapy and post-therapy imaging. What does it translate into? And I can show you on the subsequent slides if you can go to the next one. And so here is where you can see, similar to what you saw there, that in the complete response was, in terms of, you can look at the amount of activity that was administered, tumor to normal ratio was 24.9. For patients who responded well, as opposed to progressive disease, where that ratio was about 1/4 of that. So what we do in correlating our pre-therapy imaging with post-therapy delivery of dosimetry, in fact, translates into the outcome of the patients, which is what ultimately is our interest. So go to the next slide. Again, you can see one example of a patient who had a ratio of 44. And you can see how that method is derived, looking at different ROIs. And the next slide. And so we showed that the patients who had complete, response had a statistically higher tumor to normal tissue ratio compared to those who had progressive disease. Next one. And so if you can go to the next one, you can see that those patients who had favorable outcome, the mean dose was 992 gray, as opposed to patients who had progressive disease, their dose was about 1/3 of that, with 370 plus or minus. As you saw, that there's a wide range of variations between individual doses. So can go to the next one. Same concept, that ultimately what we do with all these calculations does make a difference in the outcome of the patients. And we would look forward to more and more data in the future in thyroid cancer, in the prostate cancer, in the neuroendocrine, and as these treatments are getting more and more commonly administered in other cancers, that the role of dosimetry and outcome is going to be very, very critical. So the next slide. And so we had a p-value of 0.005 in looking at differentiating between progression of disease and responders. Next one. So study structure and methodologies, you already saw some details. I'll skip through these slides very, very quickly so we can allow some time for the question and answer and discussions. So this was a multi-center trial with a recruitment target, and you saw that the recruitment was relatively affected by not only slow recruitment, but also the side effect of selumetinib. So next one. And then assessing the impact, the progression-free survival at 12 months. and investigate the dosimetry for personalization of the treatment. Next one. You can skip through these slides because we already looked at it, but I do want to insert one. You can keep going. And then I do want to share one of the slides that we just discussed at our dosimetry session in SNMMI yesterday, which is very, very relevant. So these came in very, very timely. These are the inclusion and exclusion criteria that I was able to extract from the supplemental tables that were with the article. So just so you know what was the overall inclusion and exclusion criteria. Next one. And then these were the gamma camera and SPECT imaging parameters. Again, I can't overemphasize how important it is not only to do the quality control, but also do the appropriate correction factors when it comes to multi-center trials, so you can harmonize the results in a more appropriate way. So next one. And so this is the relevant slide that I was talking about. How many time points are really necessary? And we currently struggle with this because our patients are, everybody's lives are difficult, very busy. And to try to do multiple time points improves the accuracy. But is there an opportunity to do less time points without compromising the quality of the results? So if you can go to the next one, that's the one that, in fact, I inserted from our one of the meetings yesterday, where they have done the population studies and they look at multiple time points and then see if there is a convergence at some time points in the various curves such that you can reduce those imaging time points. So this would be an important work over the coming years to make sure that we establish this balance between the convenience factors for the patients without compromising the accuracy of the results. Next one. So now in the next couple of minutes, let's assess the data results, and then also we'll go to the future directions as well. So you saw that there is an inter and intra-patient variability, which is very important to know because, this is where if we were to personalize the treatments, we need to know exactly what's happening from one patient to the other. Next slide. And then the other one here is what we talked about, the recruitment because of the side effects expected from the Selumetinib. And then a couple of patients had comorbidities that could not receive the treatment. Next one. And so this is where I highlighted in red, is that there is more work going on right now to see is it too late to wait for a state of refractoriness, or should we be considering these treatments to maximize the impact on the patients in the earlier stage? And this will be an important work, which we all await the outcome to see how we can impact more patients with more appropriate delivery of radioiodine treatment before they become refractory. And so let's look at a few things in the future directions. You already saw about the MEDIRAD and INSPIRE trials, the next one. There are certain, we talked about, we can skip this slide, this talking about the outcome. We looked at why is it important, because ultimately what matters is the outcome for these patients. And there are already emerging data in many, many cancers that it does in fact matter what we deliver to the individual organs and individual lesions is important. So the dosimetry is not only going to be important for looking at the lesions, but as you heard at the tail end of the presentation by Dr. Taprogge, that it's also important to look at the normal organ toxicity, because you need to tailor the dose accounting for both delivery of the target radiation, but also protecting the normal tissue. Next one. Next slide. Okay. And so there are some attempts. You saw some of the initial work by Ho and his group at Memorial that looked at the I-124, which was the pilot study that was referenced. There are many other studies that are looking at I-124. And so if you can go to, I'll just quickly show you a few that I found in the literature that are very, very important for looking at I-124 PET. Why am I bringing this in? Because the PET-CT can allow a better lesion detection and ROI capability. And also on the iodine side, you can in fact look at the quantitation more accurately compared to the SPECT CT. Now, currently the limitations, and I'll show you in my slide, there are that include the issues with the availability as well as approval and reimbursement. And there is this group, Joanna Klubo at NIH is running, in fact, this trial to look at I-131 iodine SPECT after therapy, comparing it with I-124 PET in the metastatic thyroid cancer. Next one. So the advantages are that, as I mentioned, it's a better assessment, measurement of metabolic tumor volume, higher sensitivity and spatial resolution of PET compared to gamma imaging. So it can allow better assessment of extent of disease. And you can do simultaneous I-124 or I-123 and I-131 administration. The next one. The issues are that the decay scheme includes few positrons and many gamma rays that can often simultaneously come out, and that becomes a challenge for quantitative PET imaging. As I mentioned, the availability and the lack of reimbursement are some of the challenges that are going on with the I-124. Hopefully in the future, we might be able to overcome those challenges. Next one. So in the conclusion, the key sentence is really the patient-specific absorbed dose planning might be the key to more successful treatment of advanced thyroid cancer. So this is a key message from Dr. Taprogge's presentation, that this is going to be a key part. So what are some of the things we can do? So if you can go to the next one. We have to do prospective identification of any outlier lesions on the planning images. So you saw the variability, but there are, let's say you have 90% of the lesions are having the iodine uptake, or 9 out of 10, but one lesion is not. Maybe that patient, instead of a binary decision of yay or no, you can in fact decide to treat, but then come up with a multidisciplinary coordination such that you can identify that outlier lesion that might become the determining factor in the patient's prognosis. So how do you accomplish that? So if you go to the next one, you have to confirm that on the post-therapy imaging once you have picked on the pre-therapy scan. And then we have a multidisciplinary care coordination that includes the endocrinology, surgical oncology, medical oncology, radiation oncology, to address that outlier lesion or more than one lesion. So for example, if that outlying lesion is a surgically amenable or has the capability to receive external beam radiation, all of those efforts will improve the outcomes by not just personalizing the treatment one patient at a time, but also addressing the lesion in each and every patient so that you can improve the wholesome outcome for each patient. So thank you.
Thank you, Dr. Ghesani, for an incredible discussion. I want to start by echoing Dr. Ghesani and congratulating Jan on an excellent work. I want to start by saying that the work that you've done changes and starts to give us a little bit of light in the darkness that has been the last 90 years that Dr. Ghesani was mentioning. We go back to that historical resemblance that he was giving us a second ago, and it seems like as clinicians and mostly people who don't treat advanced thyroid cancer outside of academic institutions or big referral centers, we're doing like a black box treatment where it goes from no iodine 30 to 100 or 150 in kind of a arbitrary way to decide activity administered. And you're giving us a total different scope to that. And I thank you for that. The standardization that you were mentioning in your trial gives us a chance to hop in a train and start broadening this body of research that you're giving. People that know me have heard me say that I compare thyroid cancer treatment to riding the train, and the train is different in every country, and you have to mind the gap between the platform and the train, and you're giving us as a good guide to how to hop on a train moving forward. So we do thank you for that. A couple of weeks back, we had one of the lectures here in the Thyroid by MD's webinar series was how do pathologists think? It was a roundtable discussion, and I think this calls for another one of how the nuclear medicine specialists think to try to bring this all back and try to bring specialized medicine to our patients. My first question, you were speaking about the before I go to my question, there's a person in the audience that has their hand raised. I don't see a question there, but if you do have a question, please send it in so we can go to that. I know I would also want to give Dr. Wadsley an opportunity if he wants to add something before we go into the Q&A. I wouldn't want to miss that.
Thank you. No, only to endorse what you've just been saying, that, you know, clearly in this day and age, it's no longer appropriate to be just having this one size fits all approach, when clearly there's such a range, you know, in the data that Jan's presented, there's such a range of uptake, and we need more of a focus on the absorbed doses being delivered. And, you know, I sometimes describe the treatment that we give for our thyroid patients with I-131 to, you know, the equivalent in external beam radiotherapy of inviting a patient into the department, putting them in a random position under a linear accelerator, and just switching it on for 5 minutes and saying that'll do. And nobody would dream of doing that with external beam radiotherapy. And I don't think we have an excuse anymore to take that sort of approach with our thyroid cancer patients. And I think individualizing and planning the treatment we give is really essential. And, you know, I think that the work that Jan's done within this study has been critical to show that, you know, there is an opportunity to personalize and do this.
Thank you so much. Going back to my question, you were saying that the study is underpowered and all, and gave interesting data. You said 64.8% of the people after 12 months were progression-free survival. What the rest that weren't? Did you find any specific characteristics in these patients that didn't have a progression-free survival, or was there any reason why the Selumetinib didn't enhance uptake in these patients?
Would you like me to take that?
So I mean, I think we looked at. Yeah, I think if you're going to go ahead, yes.
Yeah. So really the primary aim of the study was to look at the group of patients that did achieve increased iodine uptake. So we didn't actually follow or particularly investigate the patients that, so follow-ups, if they didn't have an increase in iodine uptake, that there was no further follow-up on the study, and they went on to receive whatever treatment their clinicians felt was appropriate. I think one of the important things to highlight is this was a cohort of patients who did have evidence of prior disease progression. So this was not just any iodine refractory patients, it's patients who'd had evidence of resist progression within the prior year. So they were patients who would definitely, their lesions were growing, which I think it's important to give that context, because, you know, then to find 68% not having further progression within the following year is, you know, definitely was a positive outcome. We had hoped to look at more in depth at biomarkers and predictors for benefit from this response. Unfortunately, at the time that we were running this study in the UK, we didn't have routine access to doing the molecular genetics for this population of patients. We do now, but we didn't at the time. So unfortunately, and we couldn't secure the funding to do that either. So unfortunately, we don't have details about the mutational status of those patients, which would have been really interesting and may well have informed that question.
Yeah, also there's an important another point here that you just mentioned, which is that, you know, oftentimes we do these treatments at a very later stage of the disease, and these patients have exhausted all the other means of treatment. So even in that stage, having that 68% response is quite remarkable. And as you heard, that we are now trying to look at the impact in the earlier stage of disease in the thyroid as well as other cancers. And I think that's going to be critical, because then we'll have a much higher likelihood of, you know, customizing the treatment and benefiting percentage-wise more patients. And this is where we need to do larger studies to really establish that point. So that becomes the justification of earlier treatment of these patients.
I completely agree. So I think my hunch is we've missed the boat. You know, so although we did see some increase in iodine uptake, the grades that we were delivering wasn't really enough to make a difference. But whereas if we caught the population of patients who already had fairly decent iodine uptake and could increase that could actually then make a real difference to outcomes, because we'd be delivering many more grades to those lesions. So my hunch is that the role of this treatment probably is in patients who are still iodine sensitive and enhancing that iodine sensitivity.
Yeah,
correct. Dr. Ghesani, you were speaking about how to simplifying the protocol after doing the several scans after the dosimetry to predict the dose received. Where are we right now? What do you see the future steps being? Because finally what we want to do is bring this back to the people that are treated, hopefully outside of what I call the ivory tower treatment, outside of the big centers. How do we make this a reality? What are the next?
that's a key word is, how do we scale this so that patients across different geographic regions and whether it's academic institutions or small centers or community setting can benefit from this, which is why there are these. So our society, SNMMI, works with international organizations. You saw some of the work that was quoted here through EANM, European Association of Nuclear Medicine. And we are collaborating together to come up with these studies where large number of patients can be treated to create this population pool of the washout curves, and then look at the capability of going from the need. Typically, as you saw in one of the slides, Dr. Taprogge mentioned that you need about 4 to 5 points to really come up with that curve. But hopefully we are looking at narrowing it down to 1 to 2 time points without compromising much in terms of individual patients' the washouts. And I think that's going to be critical. I personally think that it will take probably another few years before, for each individual cancer and each individual isotope, we have to come up with these data. So it will take a lot of collaboration, but hopefully in next 3 to 5 years, we'll be at that point where we'll be able to decrease that time point requirement.
Beautiful. So we've gone a little bit past the hour. I want to congratulate you for your work, Jan, Dr. Wadsley, Dr. Ghesani. I couldn't be more thankful for joining us and giving us your input in this very interesting discussion. I would want to also invite you all to be here next week. We're going to have an incredible tumor board discussion with cases presented by Dr. Amanda La Greca from Colorado, with moderation by Dr. Mike Tuttle. So hope you are all safe. Have a great weekend, and I'm gonna give you the opportunity to have your Friday afternoon back in the UK.
Thank you.
Thank you.